Good Monday morning. It is October 4th. We are live inside the Dolph Simons Family Broadcast Studio. Welcome to the Morning Medical Update. So glad you are here. October is Breast Cancer Awareness Month. It is the most common cancer for American women. We know that screenings save lives, but where you get your screening matters. We're going to share one woman's story, how doctors here at KU saved her life by discovering a misdiagnosis elsewhere. But before we get to all that, Dr. Dana Hawkinson, Medical Director of Infection Prevention and Control, joins us with our numbers. That's a big mouthful on a Monday. Good morning.
Yeah. Well, luckily the numbers are not. Actually, the numbers have been going down. We have seen, and we've seen Dr. Seitz talk about the 2-month cycles that we have seen. But, you know, here at the health system right now, we have 21 active infections with 4 in the ICU and 4 on the ventilator. Of those 21 active infections, only 3 are fully vaccinated, and none of the patients in the ICU or on the ventilators are vaccinated. So
this is a really good number relative to where we've been. I mean, you got to be happy about it.
Yeah, I think we are, and hopefully we'll hear on our CMO teleconference here this week that the overall hospital numbers are going down, because just as you said before, the hospital numbers are probably the best bellwether of the actual impact of infections that we're currently dealing with.
I think the one thing we do have to remember that is we continue to be full for transfers. We're not able to accept the number of COVID patients from the outside that we used to be able to accept. And so I think our numbers would be higher if we were doing that. But regardless at that point, because we've been in that same status for quite a while now, and what we know is the numbers are continuing to fall. And that's in sort of a quasi-stable environment. That is, we haven't been able to take transfers really for about 2 months, and not on a reliable basis. And during that 2-month period, we've seen a fall in our own numbers. So, and you see the same thing reflected in the 7-day rolling average here in Kansas City. It's dropping too. And so I think that all things considered, we're in a better place. I attribute that it all changed when we started putting masks back on. It all changed with the community health orders.
Yeah, I think so. That, and of course vaccination.
And I think the ongoing vaccination helps. Now you're hearing a few pounds here in between us. I think somebody's playing the bongo drums outside of the studio, and there they go again. Yep, and I think they're hitting the organ pipes at the same time.
Right.
It resonates well.
That's fun on
Every
a
time we
Monday.
say vaccination.
Boom! There it comes. Every time we say keep those public health orders, that's where the real bongo drum starts going on outside of us. Yeah.
Any reporters on the line today?
Yeah, sure. Hey, it's Cody with Channel 9. We'll listen for any Morse code from the banging
be careful.
here.
Is that what it sounds like? I bet.
That's right.
Yeah.
Hi, Cody.
Hey, as you talk about still being full and not accepting transfers, do you think that will change anytime soon, or have there been talks because the numbers are going down for that to change?
Yeah, we don't have plans for it not to change. Actually, we want it to change. We feel like it's our duty and our obligation to take as many transfer patients as possible, because those are people who the folks at the originating hospital don't feel like they can take care of as well as a place with more acute abilities such as a KU or other major tertiary hospitals and quaternary hospitals. And so I think we want to be able to accept those transfers. We normally take about 60-65% of transfer calls in a given month. We usually get about 1,000 calls. We've been getting about 200 to 2,400 calls a month, and we're taking around 30%. So it's just a lower number, but the volume is overall higher. And our problem is that even as COVID numbers fall, we're so full otherwise that we're struggling to take care of it. And part of it is, and we're going to hear about this story in just a minute, people waited too long to get their breast cancer taken care of, their heart disease taken care of, their neurological disease taken care of, their lung disease taken care of, and so people were coming in the hospital or sicker than ever. Even if we took out all the COVID patients, we said, what's our case mix index looks like? And case mix index is a measure of acuity. It's not a perfect measure of acuity, but it is a measure of acuity. And we normally run really high, or 1.93 or something. We've been over 2. And that's a really high number. That's like in the top 1 or 2% of hospitals. And so that just tells you that even the people without COVID who are in the hospital are really sick. And our ICUs are really full. I had a discussion over the weekend on Sunday afternoon, actually, or Saturday afternoon, one of those days, with one of our pulmonary critical care docs who's been on this program, Dr. Sutter White. We're talking about how the ICU is really full right now, even without COVID patients. And they're trying to arrange extra shifts and get extra people to work because there's more ICU patients than we would normally have, and then more places. So it's just hard right now, and there's just a lot of burden of disease. And so we want to take people from the outside. The folks who are sick, even without COVID, are sick. And if you look at those numbers, we still have 60 patients. That's 2 entire units full of COVID patients. We think that's better, but that's still a lot. And I think we're going to probably live in this 30, 60 range for quite a while unless we get 85% and 90% of people vaccinated, because we know that would cut hospitalizations by 95% from COVID. So that instead of having 60, we'd have, if I can do the math really quick in my head, we'd have about 3 to 6, and that'd be just fine with us.
Any follow-up questions?
Yeah, I just had a couple I'd written down earlier. The CDC came out with new travel guidelines as we kind of look ahead on the horizon of the holiday season, including vaccinating, masking in places of high transmission, which is, here. But do you have anything to add to that? Any advice for parents or families as they start to think about booking potential trips for the holidays?
No, I don't think that there really is not much change from last year that I could really see. They didn't take in too much account of vaccination as a whole. Certainly they want vaccinated households as much as possible for all those that are eligible, of course. But it continues to be really the same messaging following those non-pharmaceutical interventions. It's developing, your bubble. What bubble are you going to feel comfortable with? Who can you tolerate? What kind of risk can you tolerate? Masking, distancing, doing things outdoors, meeting in small groups, even of just the household. So there really isn't much change other than continue to get vaccinated and continue to, for all those eligible for vaccination. And again, hopefully we are going to be able to see the younger children be eligible for vaccination soon, get those people vaccinated.
And I just think it's the same as I'm with you. It's been the same as it's been for a while. You can travel safely. You just got to wear your mask. And I think airplanes are pretty darn safe. Airports, there's a lot of people, but we're letting people in all sorts of situations. It's crowded, and it's all about whether you keep your mask on. And because that's a federal mandate right now, I think airports are a relatively safe place to be. I just traveled this weekend up to Chicago. That's what my wife and I did to see my daughter. And Chicago's got a very strong mask-wearing culture. And if you walk into a place and you don't have your mask on, you're going to hear about it. And as a result, their numbers have been kept relatively low compared to some others, and I think that it just tells us that you can travel safely. So my advice to people who want to travel over the holidays is: A, wear your mask; B, make sure you're vaccinated; C, if you're going to go be around folks who you don't know if they've been vaccinated, you don't know how safe they are, you have to calculate your risk, because you can control your environment here. You may not be able to control your environment as well as you try if you travel. So since you don't know how they're doing it, if they're vaccinated, that's all good. If they're not vaccinated, man, if I were you, I'd play it safe.
And then last question for me. Kansas City's largest private employer, Cerner, came out Friday after the briefing, I think, and announced that they were going to require all U.S. employees to be vaccinated. And I know that you'd been reading the tea leaves there for a few weeks and months saying this is probably going to happen. I'm curious, from just a healthcare standpoint, your thoughts on this, and are you hearing of, or are you being consulted by other companies considering similar moves?
Yeah, we talk to folks all the time about whether or not and how to go about doing that. So yes, we are about in many of those discussions. I applaud Cerner. I applaud United Airlines. I applaud most of the health systems have gone to mandatory vaccination here in Kansas City. If you have not, hoping that they move in that same direction. It's kind of like that thing people say, my body, my choice. And I think that's true a lot of the time. But I think a public health crisis and pandemic changes the stories a little bit. Again, you're not allowed to drive into a building. You're not allowed to start a fire. You're not allowed to run a red light. You're not allowed, there are a lot of things that are restrictions on our ability to act completely with complete freedom. And I think that we have to just be fair and honest about that and say to ourselves, are there times in health that we have to act fairly and logically? And, you can't put lead in people's drinking water, right? That's a bad idea. And I think this is a bad idea to put coronavirus in people. And so as a result, I think that vaccination and a mandate is an okay thing during a public health crisis, and with a vaccine that has been shown to be overwhelmingly effective and safe.
Yeah, and I would like to add too, I think there are so many issues that go into making these mandates, whether it's decision at the government level or the private business level. But we know that whatever the decision is, you have to understand that from the pure medical standpoint, the non-pharmaceutical interventions work, and they're part of the correct decision-making process, and getting vaccines into arms work and are part of the correct medical decision.
And last thing I just add, if you want to keep your business open, keep your employees vaccinated, and make sure people wear a mask inside if they're not going to be vaccinated. I mean, I think that's the other thing, vaccination. I mean, I don't like wearing masks everywhere I go. I'd like to see a 90% vaccination rate so we could get away from it. We just have to make the decision that that it's an okay thing to do.
Other questions?
I have one. This is Taylor, 41.
Hey, Taylor.
I'm curious about what you guys are seeing as far as difficulty in message sharing. The consistent message has been about the people getting their vaccines, but does that make it more difficult when numbers drop like they're doing right now? Is that a tough situation as far as, yes, it's excellent that numbers are dropping and we're happy about that, but does that make the message harder to convey whenever numbers are dropping in spite of?
Yeah, you know what, Taylor, to be fair, I think panic and fear always induce better behaviors than more normative things. So, yeah, it does. But I'd rather have the numbers drop than have more panic and fear. The flip side of it is, I think the other place where we run into trouble is keeping mask mandates in place. And, some part of our metropolitan area hasn't even got a mask mandate. And other areas are considering lifting them. And my fear is that we're going to lift them just as the weather gets cold, schools are in full throttle, and the holidays are coming, which means come January and February we'll be in trouble again because we don't have enough people vaccinated. And so that's my fear. And so I think it's a two-pronged fear. I think the numbers drop, people are getting more comfortable. If the last 2 years has taught us anything, it is that when numbers get better, people want to act like things are normal when they're not quite normal yet. And as a result, we get ourselves back into trouble, and then we have to go back on to all the big public health measures. And so my suggestion is that, and I'm not a politician, so this is a healthcare suggestion, but let's not take masks off until we get to the Fauci number of 85 or 90% vaccination, Dana, because then I think we're going to be a whole lot safer.
Yeah, absolutely. And like we said before, we're reaching that respiratory viral season. And when we do that, we know that our certain units here, our bone marrow transplant and blood cancer units, we don't take the mask off for the whole of that season. So that is usually October, November, and through April as well. So, right now we're just going to be continuing it in all of the units and really trying to keep our healthcare workers safe and also the patients and their families safe as well.
Other questions? All right, we're going to get to our community questions here in just a few moments, but we want to get to our topic today. Regular breast screenings are the best way to find breast cancer early, but where you get your screening makes a difference, as with the story of patient Angela Garrison. Here's Petrania Poonswan with her story.
It's been quite a year for Angela Garrison.
My treatment is done, this course has run, and I'm on my way.
Even behind her face mask, you can see the joyful spirit that carried this mother of four and longtime law enforcement officer through her toughest times.
I found out about the breast cancer the week of Thanksgiving 2020.
A diagnosis missed just months earlier when she went for her routine mammogram at her local imaging center she's been going to for years. Her mammogram had come up negative, no sign of breast cancer. But a radiologist there detected what he thought was a suspicious nodule in her right lung. A follow-up appointment then revealed a mass in her right breast and thyroid. But a second mammogram at that imaging center also came up negative for breast cancer. That's when Angela decided to go to the University of Kansas Cancer Center, one of just 71 NCI designated cancer centers in the country, where she got a second opinion. Garrison was diagnosed with stage 3 breast cancer and around the same time, stage 1 lung cancer.
Had Dr. Naji only have been concerned about the lung nodule and not paid attention to the breast mass, it could have been a different story.
Angela underwent surgery to remove the nodule in her lung in December, and a month later began chemotherapy for her breast cancer. COVID-19 safety protocols made it pretty lonely, so she communicated with her friends and family through painting.
I made the joke that it was my me time and that it was just like a break. for a couple hours a week where I got to do what I wanted to do during a time that was pretty yucky.
Garrison finished her chemotherapy in May and had her double mastectomy surgery in June, just in time to take on a new role of first-time grandma. Garrison plans to have her breast reconstruction surgery by the end of this year. And by the way, while going through chemo, this 27-year veteran of the Kansas City Police Department was also enrolled in her final semester of grad school and graduated this past summer with her master's degree in criminal justice.
Fantastic story.
Wow.
Artist and now graduate.
Wow. Do you know her?
I do.
That's your patient.
Impressive.
Yeah, she's a
Yeah,
spectacular
sounds.
woman.
Yeah, you had told me about her, and we thought we've got to get a hold of Angela because she's fantastic and had such a great story to share. So, our guest, Dr. Jamie Wagner, she is Chief of Breast Surgical Oncology. So glad you're with us today. October, Breast Cancer Awareness Month. I know it's breast cancer awareness every single day of the year with your folks. I want to talk about Angela a little bit, and it's important to go and know what to ask when you go to get your health screenings. But what should people really be looking for when they make their appointments to get their screenings? It seems like just a regular old phone call, but is it?
It's really not. There are several things that people need to be aware of because it has become very complicated and we understand so much more about the complexities of screening. First and foremost, we want to make sure that you're an accredited breast imaging center. And within that really should be embedded fellowship trained or subspecialty trained radiologists within the specialty of breast. There are just small nuances that their eyes now pick up on due to that additional training. Additionally is knowing even how to read a mammogram. Breast density has become a very important component of what we now understand when getting the right mammogram, as well as needing supplemental screening. We now fortunately have legislation that is requiring women to be made aware if they have dense breast tissue, which was the situation for Angela that I think added to the complexities of identifying it at a much earlier stage. But that is definitely something women need to empower themselves for, knowing what their breast density is and making sure they are getting comprehensive screening. That's not just a mammogram.
So, were things being missed with dense breast tissue? Is that why that came to be?
I think that played a component as to the late diagnosis for Angela. 40 to 50% of women actually have breast density that is maintained. So we're expected to have dense breast tissue when we're young in 20s. That's why we don't recommend screening mammograms. But some women, even into the postmenopausal era of their life, will still have dense breast tissue. Well, when a dense breast is seen on a mammogram, it has a background of white, but cancer shows up as white. So it's like finding a cotton ball in snow. So it decreases the sensitivity or the ability for the mammogram to really easily identify that cancer. And that's where that radiologist and their specialty eye really is an important piece of knowing that that is a dense breast tissue. And so what can we couple with a screening mammogram to help identify cancers?
And is this what you mean by NCI designated? We hear that word. For folks who don't understand the value of that, can you help us understand that better?
Sure. So it's not just the specialty training that we know that all of the team that comes together, but it is the team that comes together. It's having a multidisciplinary team to treat any of your cancers, but that is very crucial for the treatment of breast cancer. So the radiologist, pathologist, medical oncologist, surgeon, that entire team has to come together, and that has been proven in Angela's survival.
It's a comprehensive care. Jump in if you have any questions, Dr. Seitz.
I do have a couple. So the impact of delay, does it make it even harder to find it inside all that dense tissue?
Sometimes it can, because if the cancer ends up being this huge white mass within dense breast tissue, it just becomes, it can almost mask and look like the breast is completely dense when it's just you have a very large cancer.
I have a question about, we're already getting questions from our community for you today. So we know that if somebody gets a diagnosis, an unfortunate diagnosis of breast cancer, it's very emotional. But how do you take the emotion out of it? What advice do you give people trying to navigate the emotion versus making sure that they're getting the right care and asking the right questions and getting those second opinions if they need to make sure that they're getting better.
Yeah. I don't think you can ever take the emotion out of it. That's hard to do, but I think that you can channel the emotion and make sure you're channeling it towards being your own advocate for the best health care that you can get. And that's where second opinions come in. It's not offensive to any of your providers. I myself have patients say, I think I want to get a second opinion. Absolutely. And I'll even tell you where to go for that. You know, let's get it at another NCI designated cancer center from a fellowship trained breast surgical oncologist. It gives you sometimes confidence in how you are going to be treated. And sometimes there's different approaches, and that's okay. I think as a community across the country and across the world, that's how we really want to be treating patients.
So you like it?
I was going to say, I think that's absolutely true. And if your physicians discourage you from getting a second opinion, I'd be worried about that, because I tell my patients, I mean, I send them to, sometimes I'll send them to Mayo. Really, I send a lot out to National Jewish who have this funny bunny lung disease or funny infections that I don't understand. And I think I know the people where they're going to go. I usually make the phone call to help introduce the case. I say, hey, here's what's going on. Would you help me trying to figure this out? And, you know, more often than not, they don't get more answers, but at least it gives us all a sense that we've not left any stone unturned. And I think that's to your point, that's really important.
Exactly right.
And, you know, but here's my next question. Are you guys seeing, are people starting to come back earlier, or are they still stalling coming to care?
We're still seeing people stall.
Yeah, God, that doesn't. It slays you, because you know that you can really help somebody, especially y'all. And if they don't come in soon enough, you can't get the same help for them. You change their prognosis, right?
That's exactly right. And we're very fortunate as a COC designated center with the American College of Surgeons, the Commission on Cancer. We're accredited.
You gotta say what that is. Nobody's gonna know what COC designated is.
I backed up.
Unfortunately,
he's a lot of acronyms.
Way to go, Jamie.
But I know. The Commission on Cancer is an accreditation, and it's really, again, just supporting that higher level of cancer care. It's through the American College of Surgeons. But we have partnered with the American Cancer Society. The American Cancer Society has absolutely recognized that screening is down across many screenable, early identifiable cancers. Breast is definitely one of them. And so they have a back to screening campaign and through clinical trials. And so we're fortunate to be partnering in that, because we just want to continue to advocate early screening, or screening allows us to have early diagnosis. Early diagnosis, we can treat easier and have better outcomes for patients.
It's interesting, the number of new cancers is down nationwide, but it's not really down. It's just people didn't go get diagnosed.
That's exactly right. And when we actually look at the incidence, we expect the incidence or the number of diagnoses of breast cancer to be going up this next year.
Yeah, and I think the fear is that, you know, we've gotten so afraid of COVID that we've forgotten that all these other things are out there and are getting us, and people don't want to come get care. And I also think that's true for both vaccinated and unvaccinated. I think some of the unvaccinated folks are saying, I'm just not going to go get health care right now. I think some of the vaccinated people are saying, gosh, I want to go get care, but I'm still a little scared. We want you to feel comfortable to come get care and know that it's safe. So talk to us a little bit about the things you're doing in the cancer center. Make sure people stay safe.
So obviously, as we've been talking about already this morning, masking is a big piece of that. We do still have some restrictions on the number of visitors that can accompany, because we want to keep that social distancing component. We have immunosuppressed patients that are already on chemotherapy that you could be passing in the hall and not realize it. We also are scheduling very strategically for patients to decrease the number that are in the building at any given time. Being able to schedule screening mammography in particular. We have online screening, so that also helps with efficiency. And then we have increased the level of sanitation of all equipment between patients.
Yeah, so all things, and we don't see disease transmission inside the clinics.
Right.
I don't think we've had any cases of that Hawkeye so far. Do you?
No. You know, we've been safe, really, since the pandemic began, and we've had those protocols and systems in place. Really, our patients, especially in the outpatient clinic, but even in the hospital, have been safe.
They've been safe. And so, finally, Jamie, at least from my standpoint, what can we say to patients to get them to come in? I mean, I don't think we have a waiting time, but if somebody called right now, how long before they could get to see one of you guys?
Well, we actually, depending on what their need is, if it is a workup, meaning they have something abnormal, still need the biopsy within 24 to 48 hours. Sometimes our rate limiting step is just getting images, if they've had it done outside, to us, because that's critical for our radiologist to obviously have to know what to biopsy. To see either a medical oncologist, we actually have urgent appointment, so within 24 hours they can see a medical oncologist, and typically within the week of calling they'll also see a breast surgical oncologist.
And we set that as a standard long before the pandemic, so we make sure we get everybody in.
Yeah. Absolutely. And then we also really capitalize on our multidisciplinary clinics now, where I know patients don't want to have to come in and out multiple times. So you have the opportunity to have your imaging reviewed by a fellowship-trained radiologist. You'll see a breast medical oncologist, breast surgical oncologist, radiation oncologist, all back-to-back. You stay in one room. It's very patient-centric, and that also helps.
And we want to make people feel comfortable coming to see these guys. They do a terrific job.
They do.
And we don't want the people to delay out there, because whether it's breast cancer, heart attack, stroke, COVID-19, we know that delaying care doesn't help you. And that if you're trying to deny illness, don't deny it, because it's real, and go out and get the help you need.
And I see your team down at Indian Creek for mine, and it is seamless. I was like, very rarely do you walk out of getting your mammogram going, well, that was really nice.
Right.
So, that was
that's
a
better
pleasant
than prostate
experience.
biopsies. Those are not fun.
Those are not. But we're trying to keep you from that point. So yes, that's not fun. But to make a mammogram easy, quick, everybody's so nice down there. It gets you in and out. So I appreciate that, and I know lots of women do. Can I just go back to one quick thing? Sure. And any of our doctors, all of you guys can jump in on this. But the second opinion thing. So you're telling me that sometimes you will ask for a second opinion for someone.
Yeah,
versus
absolutely.
if they don't feel comfortable, because I really do think that would be an uncomfortable thing to come to all of you guys who know what you're talking about and say, I don't know if you know what you're talking about, and I want to know if someone else knows, verifying.
You put the patient's interest first, and the patient still has questions. Get them someplace where they can get their questions.
And does that
feel
bring
like
you confidence too, to know that your colleagues out in the community, can bring something to the forefront?
I do that all the time. And then again, like I said, I sent my difficult infections and stuff. I send out the National Jewish Medical Center. They have the big mycobacteria stuff, and see if patients get funny mycobacterias. And we've been actually now developed a pretty darn good team here of our own. But even still, we'll send people out there. There's this really worldwide expert, I don't know why, but he's in Tyler, Texas, about mycobacterial culture, so we'll use them.
Yeah.
And if I have a really unusual CF case, I'll send it to one of my CF colleagues around the country. And it's just, I think that's what you do when you try to put the patient's best interest at heart. Mm-hmm. I don't get offended by that, and actually I usually learn. I learn from that kind of stuff.
Yeah, I mean, very much like what Steve was saying, a lot of us have connections, great either collegial relationships that we still work with our counterparts at other institutions. I previously was on staff, and I trained at MD Anderson Cancer Center in Houston, and so I still do clinical trials with them. If I've got a patient, I'm like, I'm going to pick up the phone. I will send them down to Houston. We can have that that conversation. The patient, actually, I've had patients call back and say they knew what I was coming for. And they appreciated that, and it actually, I think, enhanced that second opinion for them.
Sure.
And they got answers, and that's what it's about.
I've done stories with you where you said sometimes I am the second opinion, and sometimes I have to send people out for the second opinion.
Yeah.
So,
the bottom line is, very sincerely, we want patients to get the best medical care that's available. And we strive every day to do that at the University of Kansas Cancer Center and with the health system across the board. But part of that is looking and thinking kind of outside of the box. And that's, I think, where those second opinions and that collegial atmosphere really plays an important part.
all right, we've got some good questions coming in. Do you have anything to add, Dr. Hawkinson, before we get to that?
No, Jamie.
She wrapped it up for us.
There's really nothing else I can say except listen to her.
Listen to what this lady says. Okay, good advice.
Keep yourself healthy. hopefully your family won't suffer any tragedy, and listen to Dr. Wagner.
And get your screenings. Okay, before we get to today's questions, I do have to ask, one of our viewers, Karen, has a question, and I promised her I would ask you. She says she cannot find an answer anywhere, so
Oh
I
boy,
have to ask.
I'll get a second opinion.
So Karen says, I had 2 Moderna shots 8 months ago. She has stage 3 kidney disease. She has 1 kidney. But she had a really bad reaction to the second Moderna shots, and list a bunch of things that went on. 102 temperature. It just went on, lasted 4 days. So bad headache, you name it. So her question is, since my 8 months is up on October 4th, today, do I risk taking the full Moderna 100 micrograms, 3rd shot, or do I wait for the Moderna 50 microgram booster
Well, I don't
to
know.
be approved in the fall? So
Well, I don't know that it is going to be a 50 microgram booster.
Okay.
So let's first of all qualify that. We don't know that. Second of all, we don't know when a booster from Moderna is going to be available because their data continues to look really good.
Yeah.
And third, what we've learned from the boosters that have been given Hawkeye, they're no worse than your second shot. So you may have been sick, but you're not going to get more sick after your 3rd shot.
So I think that's the important point to this question. So far, what we have seen is exactly like you said, the rate of bad side effects. But also, if you know you had that the second one, you can prepare. Obviously, they talk about hydration. If you start feeling symptoms, you can take some Tylenol or ibuprofen. But I think she would fall under that category of more at risk because of her kidney disease. Not necessarily for the recovered breast cancer, but certainly for the kidney disease. And why are they recommending boosters? Again, because of what they saw in the older populations that, especially now with the real world experience, those older populations do seem to have better chance of staying out of the hospital. But I think your other point is, we don't know exactly what the guidance will be on Moderna. You are still well protected. And we're not sure, will it be the same dose or will it be a lower dose? So I think we really need to wait for further guidance on that one.
So what about Pfizer as an option for her?
I wouldn't.
Taking that
I
now.
don't think I would switch. First of all, the Moderna vaccine looks really good, guys. I'm just going to say to you, in terms of its long-term sustainability, Moderna is number 1, and followed by Pfizer, followed by J&J. I think J&J is going to get a recommendation for a booster relatively soon. Mm-hmm. I think Moderna will too. I just don't know what the time interval is going to be, and I don't know what the dose is yet. Do you?
Yeah. So I think to the question, I think in extenuating circumstances, you can mix dosing, meaning Moderna and then Pfizer, or Pfizer and then Moderna. But that is, again, not recommended even for anybody going through their first dosing. So right now, hold tight. But otherwise, I did see a news blurb today that Johnson & Johnson will be submitting soon for that booster dose as well. So, but I think, hold tight. If the opportunity comes up to get a 3rd dose of Moderna, you should go about it knowing and understanding it will, likely provide you more protection, but that it will be safe. But just prepare for those symptoms that you may get post-vaccine.
I think that's right, but I think it's better than getting COVID.
Absolutely.
You don't want to have that one. And so I think you should go and get that 3rd shot. It's also no secret that people go out and get another shot right now if they want to. But we're not recommending it to folks. It's just that some people will go out and do that.
I think if you're continuing to do things and not, anticipating getting into those other high-risk situations, a lot of things and a lot of initial wording and messaging that came out from Dr. Fauci and the CDC about offering and wanting to give further dosing to those that are under that age of 65 is in an effort to help reduce transmission as well. But how long does that ability to reduce transmission last? Is it 3 months or 6 months after? But overall, the protection against going to the hospital and going to the ICU continues to be extremely high for all the vaccines.
Yeah, I mean, the protection against death is still 98, 99%.
Yeah.
I mean, it's really strong. We're not seeing increased death amongst vaccinated people, even though they've been vaccinated for almost a year now. Yeah. So we're not seeing that. What we're seeing is more hospitalizations.
And I had a talk with Matt Mason, one of our great ID pharmacists, who's done a lot with vaccination and education about vaccination in the health system and around the region. I don't know where all of this conversation will be in 6 months. I suspect it will be a free-for-all, and some of these questions that we're having right now are really not even going to be very significant at that point. But
I think you are going to get a Moderna booster. I just don't know when.
Yeah.
I think J&J booster is going to occur, I've read today, 2 months after the first shot. And then, so I think that's probably what they're going to align up to, and then we'll see how long it sustains after that. We already know what the Pfizer schedule is. So My only question is, Moderna, is it going to align with Pfizer or not? I don't think we know the answer to that yet. I'm interested to see what the CDC says. I think the FDA advisory panel is meeting, gosh darn it, was it the end of this week or next week to have that discussion.
Yep.
All right, Dr. Wagner, here we go. Angie wants to know, can you comment on thermal imaging mammograms versus traditional mammograms?
I'm going to assume thermal imaging mammograms, you're talking about thermography, which is not a mammogram.
Okay.
And it is not approved as a method for screening. So we really need to be looking at true screening mammography. Pretty much the only thing that is now available is digital. And we also know the benefit of what people refer to as 3D, which is more formally known as tomosynthesis, because that does help overcome some of that dense breast tissue and has a higher identification rate for the radiologist.
So Catherine says, if I already get a 3D mammogram because of dense breast tissue, are there other questions I should be asking?
Yes, 3D mammography is wonderful for dense breast tissue, but we also know there is benefit from getting supplemental screening. Historically, we've used breast ultrasound, and we now have the opportunity to utilize new technology with abbreviated breast MRI, and that becomes a little bit more of an in-depth discussion with radiologist and your primary care physician ordering your screening mammography of if you would be a patient to benefit from the MRI.
And you have to worry about insurance payment too, right?
That's the
a
big
deal.
thing with abbreviated MRI. That's why it has to be a very careful conversation. We know that having done our own internal audit on our supplemental ultrasounds, they get covered by insurance. Abbreviated MRI is such new technology. We're just a little bit ahead of the curve on that, and there is not a code, so no, it does not always get covered by insurance.
Which is a fun because it looks pretty good data-wise.
Yeah. And then, we understand that, and so we also, for patients that are interested in getting it regardless of insurance coverage, we do have a cap of $500 and it's a true out-of-pocket expense. And that's a conversation, though, that we will have with the patient up front.
So along that topic, Isaac wants to know, why would Angela's first mammogram reading have returned negative? Is that less sophisticated equipment? Why so wrong?
Yeah. I would not make the assumption it's the equipment. It is like the perfect trifecta, I guess. You have to have the right equipment, which I'm going to assume that they did have. We do a ton of additional training with our technology, or our technicians, the mammography technicians, on how to place the breast, what's the right compression, how it is technically done delivers the picture then for the radiologist. And then you need the experience of the radiologist. So it takes all three components. I can't say specifically, hindsight's always 20/20, and I know that I have that now. I don't know which aspect of that may have played a part. But we know that those are the three important components.
Good to know. I know when they have to go back and do it again, it doesn't feel good, but it makes you feel like, wait a second, I don't know if we had that right. We're going to go back. And you guys do that a lot. And I'm always like, are you sure you didn't get it the first time? But you know that they're saying there's a way to do this right, and I don't feel like I got it right, and I think I need to read more, and that's always very reassuring.
Yeah.
So I appreciate that. I know
Jess,
women
I'm
do too.
going to have to pop out. But
Why are you leaving us?
Well, I have to go be part of this call for the
Boo.
medical school accreditation. So I just want to say thank you.
Thank
You
you.
guys do such amazing work.
Thank
These
you.
guys are the A-team.
Okay, so you're coming back tomorrow.
I'm here on Wednesday.
Wednesday, see you
I'm
Wednesday.
here Wednesday, open mics, Dr. Stites. It's
Okay.
going to be a good
Yeah.
conversation. So have some
Okay.
fun this week. See you guys. Sorry.
See ya. Bye. See ya. Okay, we've got some more of these questions, so we will handle this. Let me ask you about this, Dr. Wagner. Are there other places in Kansas City that have these teams that you've been talking about? Okay, you can't be the only one. How do you know? She's saying, KU's one of the best. So how do you know, and how do you look up to find out if they're as good as we are?
That takes a lot of homework.
Okay, well, is it a Google search? What is
it? That's a kind of a hard question to answer. You can have also people listed on your website. It's also how they come together.
Yeah.
Right.
Right?
Yeah.
What
Yeah,
can you
I
add
feel
to
like
that? Jump in
I
there.
mean, I was going to say there's a lot of football teams in Kansas City as well, but there's only one Chiefs.
Oh,
So,
Yeah.
I like that.
promoting our health system. But for all those reasons that Dr. Wagner talked about, it's all about the team collaboration. So
Okay, that's good to know. I'll take that.
we know
answer.
that there are other great physicians out there in the Kansas City area, but I think it's about the team collaboration.
Yep. Well said. Barbara says, so if I have dense breast tissue, I should come to KU for my annual screenings. Sounds like a lot of it depends on the radiologist's interpretation too. So she said her breast cancer was detected thanks to mammogram and radiologists who noticed the change. But should she now, from now on, start coming to KU?
Well, I'm going to advocate, obviously, for that. But part of it is we have been paying attention to breast density before it was kind of like a thing to pay attention to, right? We actually have a full dense breast program where patients can come see one of our specialty trained advanced practitioner providers, like physician assistants that literally work side by side with the surgeons. We review the imaging. They will do education. There's also times where women say, I have dense breast tissue because of my breasts feel lumpy bumpy. But breast density is actually a diagnosis by what your breast looks like on a mammogram. So we will go through that whole process, and then at the end of that consult, make sure that you're leaving with the right recommendations on what imaging should you be getting.
Sandy wants to know, is there an age where breast cancer begins to fall off? Like over 65? Is there a
Yep.
sweet spot where you really need to be paying attention?
Well, we know that the highest incidence is women in their 50s, 60s, and 70s. We do pay attention to 40, which is why as a breast community, we still recommend for mammography to begin at the age of 40 and to do it annually. Although women in their 40s don't have the same number of diagnosis, we know that when you get it in your 40s, it is typically a more aggressive cancer type. And so that's why we do want women to start at 40, but that 50s, 60s, 70s is where we have the highest number.
Because it used to be 50. How long has it been 40? Because that doesn't feel like that long ago.
It's actually been 40 for several decades.
Okay. Well, maybe I just missed out on that. I'm just so,
No. It actually became very confusing.
But was it required? I mean, but would insurance pay for it? Was it something? Okay,
Yeah.
so then at 40 you got it.
Where
okay.
it became confusing is several years ago, the United States Preventative Services Task Force modified recommendations.
Okay.
And so there's a lot of recommendations out there. You can look at their recommendations, which we have more up-to-date data, I think, than what that was afforded for them to make a decision. But if you look at, American Society of Breast Surgeons, Society of Surgical Oncologists, ASCO, American College of Surgeons, I mean, we can go on and on of all those accreditations that we really would advocate more for starting at 40. And you can have a conversation if annual or biannual every other year is best for you. We as a breast community would still say annually. And, I think if anything, COVID has taught us that. If we had ever questioned how often you need to get a screening mammogram when women stopped getting them, we're seeing women now come in that they missed during our shutdown, where they didn't have a choice.
And then they
we shut it down.
A whole other.
And then they waited that time, and now at their diagnosis are a little bit more advanced than maybe we otherwise would have seen.
I don't know why I had 50 in my head. Maybe it was because the women I was around or someone I knew had put it off, which brings me to my question, which is, why don't women want to get that screening? We hear different, men don't want to get screened for certain things, women don't want to get screened. Is it because it hurts? Is it because you don't want to know? What do you hear from women?
I think that the discomfort is definitely one. The pain or discomfort, I think it's a spectrum for what experiences can be. I think the other fear that is out there is the amount of radiation exposure, which it really is very minimal. Radiation exposure. I mean, flying across the country in an airplane provides about the same as a screening mammogram, or even less.
Did not know that.
Yeah. So that radiation exposure, I think we just need to educate, and advanced technology, I think, is helping with that too.
Let's talk about men and breast cancer. I mean, let's not leave our guys out. What should we know? What should they be looking or feeling for?
We don't do screening mammograms, obviously, on men, but we want them to be doing self-exams or self-awareness, just knowing what your body is. If you feel a lump in your breast or, a something has changed, have somebody take a look. We do mammograms on men. So if you do have something abnormal, you can do a mammogram on a male and identify a cancer. Knowing your family history for men, I think, is a very important piece of our entire story.
The women in the men's life. So if a man has a mother or a grandmother or a sister with breast cancer.
Right. Or prostate cancer at a young age.
So any cancer.
Right, because we know that a lot of male breast cancers are genetically driven from mutations, and we forget that men can get breast cancer, I think, sometimes. Just really understanding that history, because if there are a lot of women in the family, maybe a genetic mutation was never tested for.
And you mentioned it, true or not true, that you are not, I don't want to say recommending, but promoting the self-breast exam that we've heard for many, many years. I mean, do them if you do them. Don't stop doing them. They can't hurt. But you don't want people just relying on that, correct? Tell me the thinking behind that.
Right. I definitely want them still to get their screening mammograms. We had the kind of old school days where we had these shower cards and you were told to do it a certain way and do it every month at the same time. And there was a very large study that showed that did not improve the identification rate from women who were put in a different category of just what we call self-awareness. Just be familiar with the body, and if something changes. So we do still want women to know what their body is, but there's not a right or wrong.
Were people relying on those self-exams to say, oh, didn't feel a lump, so I don't need to get my annual mammogram?
It was actually the opposite, because they thought that there was a right and wrong way of doing a self-exam. They said, well, I don't want to mess it up, so I just don't do anything.
Gotcha.
So they weren't feeling anything at all because, they were afraid of doing it wrong or the wrong time of the month. And I understand that. We as a health community push that on them, and unfortunately we've learned differently.
Oh, so it had the opposite effect. That's interesting. Okay, if we could just stick around a few more minutes. I do have some great questions, and while you're here, I want to make sure that we answer them for our viewers. Holly wants to know, do implants cause a person to have more dense breast tissue? Because I think goes back to what you said. It's something that you see in the imaging. It's not the way it feels.
Right.
On the outside. It's on the inside.
That's right. Nope. Your breast tissue is just how it is. It's whatever your body type is. It does not make a difference if you have an implant or not. When you go in for your screening mammograms, we'll take a couple extra pictures because we are able to do what we call implant views. So a normal screening mammogram where you can actually see the implant, and then the radiologists technically have a way to displace the implant, so it's only seeing breast. And that's the important piece, is that you get both views.
So small breast, large breast has nothing to do with breast density. You can have small breast and it's in there.
Yep.
Okay. I think it's just the word. When we think dense.
Oh, yeah.
We think big.
Yeah.
We think thick. Okay. Let's just call it what it is. Catherine says, should women with dense breast tissue ask for additional screening, or will they just be advised for that additional screening?
That is a great question. The FDA is coming up with actual verbiage, and that exact required verbiage on the bottom of a screening mammogram I think is still being determined, but it will come on your letter that you get about your mammogram, that it should say if you have dense breast tissue or not, and most of the time it'll say follow up with your provider. So at that point it is in the patient's hand to follow up, ask their provider, I have dense breast tissue, now what do I need to do? And it is a lot for primary care doctors. They have a ton of work and understanding. It's just all of medical care has become so complicated, and that's really why we have the dense breast clinic, is so that they can then refer patients for us to pick up, and that's what we feel like our role is in this journey.
Okay, a few more questions. Fanny says, how rare is triple negative breast cancer?
So it is, I guess, in the grand scheme of it's our most common is a hormone positive HER2 negative breast cancer, but we definitely see triple negative breast cancer. It is definitely what we would probably consider our most aggressive of our different tumor biologies. We are extremely fortunate at University of Kansas Cancer Center. We have one of the nationally recognized medical oncologist, Dr. Priyanka Sharma, who does research in that arena and is well known for that. So we do treat a lot of triple negative breast cancer here.
And does breast density have any correlation to that?
It does not.
Hereditary?
We know that women that have a BRCA mutation, BRCA1 mutation in particular, we see more triple negative breast cancers in that population.
Okay, Deborah says, if you have fatty breasts and find a lump, could it just be a fatty cyst?
It could.
But should you get it checked out?
Yes, you should.
Okay. Don't be your own doctor when it comes to that.
Don't do your research in that.
Exactly,
Right.
exactly.
Go to the expert.
Go to the experts for sure. Okay, hold on. I do want to make sure I'm getting to everybody's question. Okay, Vicky says, I was told once that you should get your mammograms at the same place because they compare last year's to this year's and changes. Is this true?
That is true. For that very reason is we have a normal baseline, then we always want to compare because, you know, if something wasn't there last year, well, let's take a deeper dive this year. But we have to couple that with having the entire team to make sure you're getting the great mammogram for them to read to begin with. For patients that want to modify where they go, I mean, sometimes it's because they've moved or whatever reason they want to change imaging centers. The cloud, that's where technology has come in. We can cloud those previous mammograms over so then we have those available for comparison.
Okay, Donna says, she said, well, this is a little concerning, something you said earlier. So if we're going to a regular imaging center related to another hospital here in town, then they could just be missing a diagnosis. She's been going to one in particular here in town. How does she know if it's accredited? How does she find out if that's where she should be or she should step it up and come somewhere else?
Most imaging for breast imaging in particular, accreditation, they have those listed on their websites.
Okay. Let me see. I think we're good. Okay, I'm going back through because somebody wanted me to ask the rest of their question. Hold on just a second. Everybody hang tight. I've got this other question I want to ask you. Just hang tight, everyone.
Well, as you're looking, I think
Please do.
I know and understand why Dr. Stites will not be here tomorrow. I don't know if he said he had a meeting or something, but I think really what it is, I think he's going to be raging tonight because I just saw a headline that William Shatner is at 90 is headed to space. So I think
No way.
this is the culmination of everything Dr. Stites has been dreaming about, and so I believe he's probably going to be partying pretty hard. So that's probably he probably won't come to work tomorrow. So.
I thought. Thank you
He's
for
going to
doing
be
your
in
research.
celebratory mode.
I knew you were over there figuring that out.
I'm looking for those hard-hitting stories, really.
Yeah, no, it's a good angle. It's a really good angle. Okay, so Fanny had asked about how rare triple-negative breast cancer. She really wanted me to ask this part of it too, and I didn't skip over it. I was just trying to consolidate. With a sister who has navigated this as a Caucasian Jewish woman in her 70s, what is the stats on me with dense breast getting it too? She is Jewish as well. Does that have any... does that make any difference? Should that be a bigger concern? And what advice would you give her?
It's really the overall global health, and I think that this is a really great question that she highlights.
Good. Okay,
is
thank you.
Understanding your family history, but also your descent, because we know that women that have an Ashkenazi Jewish descent have the potential for having a BRCA mutation. And so like I was mentioning, we see triple negative breast cancers and BRCA1 mutations, and then they're adding all this family history. So they really should be seen in our high risk group. It sounds like her sister's already had breast cancer. And so from that standpoint, seeing a genetic counselor or, one of our providers in our high risk group would help stratify basically do a risk stratification. Genetic testing is very likely would be indicated as part of that potential conversation. And we always want to try to test the person who had the cancer. I have a lot of patients who come in and they say, I just want tested because my aunt or my grandmother or my mom had breast cancer. And that fear I understand and I respect where that's coming from. But if you don't have cancer and we test you and you're negative, that's actually non-informative. It doesn't mean that that person that did have cancer didn't have a genetic mutation. It means that you just didn't get it.
So you're saying in Fanny's case that the sister who did have it, the triple negative breast cancer, you could test her as well, and what would that tell you as far as then the sister, Fanny?
So if the sister who had breast cancer had a genetic mutation, then the question that's being asked, she would absolutely be eligible, and we would want to test her equally for that mutation.
So she's just not the person who should be going in for that regular mammogram. She's done her work and she knows her history, and so she should.
Well, so she needs to definitely be doing her screening mammogram. I feel that right now that family is in a bigger conversation than we're going to have here, but
right.
She should. They really should be seen in the high risk clinic, so they can have a comprehensive conversation, risk stratification, and genetic testing if appropriate, because women who have a genetic mutation have a lot of options that we then want to discuss on how can we lower that risk of breast cancer for everybody in the future.
Nobody skips out on mammograms, but you're
Right.
saying she needs to take it a step further now that she's understanding her history. And we
right.
did take care of her sister. She said her sister got excellent care, so we are very happy that she's doing well. Last questions from Melissa. What's the list of annual checkups for a 45-year-old woman? What should they be doing? All types of screenings.
Wow.
It's a great question.
Okay, mammograms, we know that.
Obviously, we want you to get
one.
screening mammograms. Making sure you have an annual primary care doctor visit. I don't think I can advocate for that enough. I think women, especially in their 40s, right where she is, very busy women, either in the home, with children, careers, all of that. We put our healthcare on the back seat a lot. And it is amazing what a great primary care doctor will help you with. They're going to, look at your skin because, unfortunately, maybe we didn't have such great sunscreen, back at times.
Baby oil is not good sunscreen.
It is not. It is not.
In the 40s, that's what we used to use.
That's exactly right. And that's exactly what was coming to my mind. And so just having an overall skin check.
Is that a physical? Do you mean by that blood work? When you say an annual visit with your primary care, you're meaning the full workup?
That's right. Yeah. They'll do, regular labs to make sure that everything is looking appropriate there. And they're the driver for making sure that you are on time with all that correct screening. When is it the right time to get you in for your first colonoscopy? And ironically, you may say something that, you're like, I've had this for a couple of years and it means nothing to me and I feel fine. But that in combination with maybe something else you say to that primary care doctor says, let's work that up just a little bit more.
Great advice. Okay, thank you for all these fantastic questions. I had to extend the program today because we have Dr. Wagner here. So sorry, I had to make sure I got everyone's questions in. And if I missed one, please send it in and I will ask Dr. Wagner personally and I will get back with you on it. Final thoughts from you today. What do you want us all to know?
Oh, wow. We had a phenomenal conversation. I want to thank all the folks that called in or texted in. Screening mammogram, please don't put off any longer and be thoughtful on where you're getting your mammography. We have a phenomenal navigation line. Just give us a call if you've got questions. We want to be that resource for people.
Thank you for all the work you do. We appreciate
you
all the time. Dr. Hawkinson, thanks for sticking around. I saved all these booster questions and all sorts of good stuff, and we'll get to those tomorrow. But what are your final thoughts today?
I think it was a great episode. Definitely listen to Dr. Wagner and get in with her team. Screening is very important. All over we had a good question about general screening. I think the best thing to do is follow up with your primary team. But things you want to do, just as she said, skin checks for skin cancer, the colonoscopy. If you're a smoker, maybe high-resolution CT to look for lung cancer, things of that nature. Of course, the breast checks as well. So just overall keep healthy, and one way to continue to do that is to get vaccinated as well. So make sure you're up to date on all your vaccinations.
Thank you both. Appreciate it. Thank you for being with us today. Tomorrow we are back with infectious disease doctor, Dr. Nathan Barr. The topic, monoclonal antibodies. A lot of you asked this question. Why doesn't just everyone who tests positive get them? We're going to talk more about that. We look at who is a candidate, and we hear from a patient here at KU on how it's helping him in his fight against COVID-19. Have a great day. We'll see you back here Tuesday at 8.
Subscribe to our morning medical update and open mics with Dr. Stites podcasts. now everywhere podcasts are available.